Hi guys, in this video I'm going to cover everything that's in our lab. From all the way from the beginning of the semester till the end. It's in one file. We started with the bacteria, broad and vs narrow antibiotic. So the broad we use for everything else other than gram-positive, and narrow is for gram-positive, the bacteria that has thick cell wall, the multi-peptidoglycan cell that shows purple on the gram stain. And if there's a question showing you the circle with antibiotic, you can choose either intermediate or susceptible. Susceptible will be the best. Resistant, obviously, that doesn't work to kill the bacteria. And the difference between sympathetic and parasympathetic. In sympathetic, the smooth muscle at airway relax, dilate, more oxygen goes in for providing the muscle contraction. In parasympathetic, we increase airway resistance and promote lower respiration rate that triggers more parasympathetic. That's how meditation work. If we control the breath and make it slower and then exhale more, that will trigger more parasympathetic nervous system. In asthma, more mucus will be produced, and it happens in hypersensitivity type 1. COPD, we have two types of COPD, even though the result is the same, which is CO2 retention. Type 1 is because the airway is narrow, which retains CO2. The other one is because the alveoli at the end of the lung is damaged. That prevents the exhale of CO2 and cause CO2 retention. Chronic bronchitis, emphysema. This equation appears a lot in this semester. I'll explain later when we talk about. No, I'll explain right now. So if when we have CO2 inside of our body, it will automatically combine with the water, and then this reaction happens. Don't mind too much about this bicarbonate acid, I think it's called. Anyways, I'll look it up right now. H2CO3, carbonic acid, and then becomes bicarbonate and hydrogen. So that's why often we say CO2 is acidic. Actually, CO2 is just a gas, but it's this equation that makes, because once it associates with water, it becomes hydrogen, which makes the environment acidic. And this one will be excreted through the urine by kidney. And bicarbonate is it's a alkaloidic. And the same reaction happens if we have bicarbonate and hydrogen. It will push the equation backwards. and have CO2 and water. All right. In normal, so we're talking about breathing rate. Normally, in a healthy person, the breathing rate will be determined by the level of CO2. Whether it's high or low, there's receptor, there's cells in the medulla getting this information and determine whether to breathe fast or slow. But in COPD patient, their CO2 is always high. So the medulla can no longer use CO2 and hydrogen for this to determine the rate of breathing rate. That's why they use in COPD patient, they use oxygen. That's why in hospital, we only keep the COPD patients O2 set a bit lower than they require to drive their brain, their medulla to breathe faster. Otherwise, if it's higher, the brain will think, I don't need to breathe fast, and they end up breathe slower, but they already retaining CO2. And here's the cellular compensation for pH imbalance. So at the cell level, they'll always help with the pH balance. If it's acidic, we have lots of H outside of the cell. The H will move into the cell, and in reverse, we always balance the charge. So we move a positive outside, which is potassium. And if the opposite happens, it's alkalotic outside, that means we have less H, less hydrogen out. So the cell will move the hydrogen out and move potassium in. This one you guys know already. And how do you determine the intracellular, extracellular? So here's the line here. Inside of the cell is the intracellular fluid. Anything outside, including the interstitial fluid and then plasma, are considered extracellular fluid. In the extracellular fluid, we have more sodium, and inside there's potassium, protein, magnesium, phosphate. This one is trying to tell you that brain cell is sensitive to the osmolar concentration, the amount of solute in the fluid. When we have hypernatremia, for example, too much salt in the brain extracellular fluid, the brain cell will shrink. And the opposite, if we have hyponatremia outside of the cell, this cell will expand. And the person will end up have a swelling brain. Each will affect the mental status. Okay, let's talk about diabetes. No, I think it's diabetic insipidus. That is when the person is lacking the ADH. ADH is the function. Let's talk about the function first. What does it do? It inserts aquaporin in the collecting duct of the kidney and reabsorbs water back into the body. It's usually secreted when we are dehydrated. So when ADH is secreted, we won't get dehydration. But this person is unable to secrete ADH. So that will lead to dehydration of the body. And dehydration of the body leads to hypernatremia, and that will shrink the cell, especially the brain cell, and the person will get headache, nausea. How do we treat it? We give water slowly, because in the originally when the person is dehydrated, the brain cell is adapting to this environment. If we give to treat this patient, if we give the water too fast, that will lead to swelling of the brain cell. That's why we give it slowly to avoid edema. What happened to potassium in intracellular fluid if extracellular fluid has decreased potassium? So the answer is the potassium inside of the cell will move outside. That won't, because we always have protein inside of the cell. If something positive move outside, then that makes inside of the cell more negative. And when we look at this graph, so we have hypokalemia in the extracellular fluid and a positive move out, which makes inside more negative. So that moves this graph downwards. Look at this. Originally it's -70, and making it more negative, let's say -80, is moving away from the threshold. So it's harder to reach the action potential. And that makes this neuron harder to fire signal. And that will lead to tingling or weakness of the muscle. The opposite, hyperkalemia, if a positive charge is moving in, that makes inside of the cell more positive. So -70 becomes -60, which is closer to the threshold, and it's easier to reach the action potential. So that makes there's excitability in the muscle. However, because they have less time to rest, so the contraction in reality is weaker, even though it's faster, but it's weaker. For example, in the heart quivers. Insulin, we all know it helps move the potassium in and hydrogen out. That's why we look out for it's used when we treat the hyperkalemia. However, we need to look out for high acidity. So you see that for potassium, when it has less in the extracellular fluid, it makes the muscle harder to contract. And if there's more in the extracellular fluid, it makes it easier to contract. More means contraction, less means weakness. This one I talked before. If it's hyponatremia in the extracellular fluid, I suggest in exam you can draw this picture, a circle, and makes extracellular fluid less, more in the inside. Naturally, the inside will move out, and hypernatremia will make more sodium into the cell, because we already have a lot in the, oh wait, sorry. It's the movement of the water. So if we have less salt outside, then naturally the water will move into the cell. And if we have too much salt outside, we will move the water out into the extracellular fluid. The cell will shrink. So let's talk about how the other two electricity electrolyte affect the neurons. Calcium will, if has the effect, if we have too much calcium in the extracellular fluid, it will cause the voltage gated sodium channel close at the beginning of the neuron, at the dendrite. So at the beginning of the neuron, it looks like this. And this is at the end. We need voltage gated sodium channel at the dendrite. Yeah. So too much calcium will close down this sodium channel and makes excitability harder. So more calcium outside of the cell, weakness of the muscle. Hypermagnesemia. So if we have too much magnesium, that has the effect at the end of the neuron. It's here. It closed down this voltage gated calcium channel. And we know that we need the calcium to rush in so that the neuron can release the neurotransmitter. If this gate is closed down, then this neurotransmitter cannot be released and makes the muscle weaker. The communication is cut. And here I have a side note. When we have high level of calcium that overwhelms the filtrate in the kidney and makes it hard for the filtrate to reabsorb water, and that will lead to high polyuria and dehydration in the body. Polyuria in the kidney outside. All the water is excreted. This one I mentioned. A side effect will be of too much calcium will lead to calculi, because in the kidney tubule we have phosphate, and when we excrete too much calcium out, it meets with the phosphate and creates kidney stone. Hypocalcemia will lead so more calcium makes the neuron hard to fire, and hypo makes neuron easier to fire, so that leads to excitability, increased heart rate, numbness, yeah, paresthesia. I think that's the too much overactivating the neuron. Okay. So the pattern is for potassium, more potassium we have, more contraction. Less potassium we have, less contraction. But for calcium and magnesium is the opposite. The more we have, the less contraction we have. The less magnesium and calcium we have in the extracellular fluid, we have more contraction. Okay, this one I also mentioned. Okay, let's talk about chloride. Chloride usually is ingested through food and it goes into the blood. And then calcium chloride is going through the parietal cell, going through the cell, through this channel, and then it goes to the stomach. Stomach has a lot of hydrogen. Hydrogen react with chloride and make the gastric juice. And then at the same time, it will continue, this cycle will continue, the stomach gastric juice in normal time will go to duodenum. And at the same time, we're having cell respiration, at normal respiration. So CO2 and this reaction happen, we get bicarbonate. Bicarbonate will go into the blood, and here H hydrogen is going into the stomach. And bicarbonate goes to the blood, it flows to pancreas. It flows to pancreas and make pancreatic juice. Here I'm talking about normal days. And then pancreatic juice will go to duodenum. So gastric juice and pancreatic juice meet in the duodenum. Note that the gastric juice is very acidic and pancreas juice is made with bicarbonate, so it's alkalotic. So these two meet and the pH is balanced out. And then they digest the food, then bicarbonate, so everything is balanced out. At the end, the urine and everything else should be balanced pH. But when we have vomiting, so the hydrogen is vomited out. So when the pancreatic juice comes here at the duodenum, it doesn't have anything to neutralize the base. So the bicarbonate flows out through the kidney, which cause metabolic alkalosis. So you know that the chloride's function is to make gastric juice. And this process of vomiting is the cause of metabolic alkalosis. Now let's look at how to determine whether it's respiratory alkalosis or acidosis, or the opposite, metabolic acidosis or alkalosis. So the way to look at it is always look at the pH first. Let's use this example. I'll walk you through. The idea is always the same, just follow it step by step. You can write down how to do it on the side of the question before answering. First, look at the pH. Ask yourself, is it acidosis or alkalosis? So I'll write it down to make it clear. Okay, let's say, so 7. 7 is acidic, acidosis. And second question you ask yourself, CO2. Let's look at CO2. Is it acidosis? Is it alkalosis or acidosis? So how do you determine whether CO2 is? So like I mentioned before, the CO2 itself is just a gas. It's not either alkalosis or acidosis, but here I'm just simplifying it. You can In your mind, you can understand it as CO2 will cooperate with the water and then push the equation to the right and produce hydrogen. So more CO2 means more hydrogen, that is acidosis. So the larger number CO2 is, the more acidic it is. So let's look at this. 66 is more than the normal range. So you write acidosis. And the third question, look at bicarbonate. It's the same. Is it alkalosis or acidosis? So this bicarbonate, you know itself is its alkalosis. The more we have, the more alkaline it is. So we look at it is 50. The more we have, the more alkalotic it is. Okay, now we can ask ourselves, now we're at the fourth step. Which one is causing the current pH? Which one? So CO2 align with the result of pH. We know that the answer is CO2. CO2 is respiratory. But we do not, and we know that it's respiratory acidosis. Next step, how do you determine whether it's compensating or not? So to determine whether it's compensating or not, we look at the other system that we are not using. So we look at the number of, wait, I'll write compensating or not. How do we do that? Is by looking the HCO3. It's looking at the other system's number. If it's outside of the range, that means it's compensating. If the number is 26, even though it's at the more high end, it's not compensating. So it's really like straightforward. If it's from 22 to 26, it's not compensating, but here we have 50. So you ask yourself, is the number within normal range? If the answer is yes, that means it's not compensating. If it's no, like 50 is out of the normal range, you say yes, it's compensating. Now the last step. Is it full compensation or partial compensation? Look at the pH. If the pH is within this normal range, means it's fully compensated. So between 7.35 to 7.45 inclusively, that means it's compensating, fully compensated. If it's like 7, it's out of the range. So it's partial. If the previous, that depends, like the previous answer, if it's compensating, then we lead to number 6. If here at the 5th step it's not compensating, then there's no matter of fully or partial. We don't need to go to step 6. But in this example, we are compensating, so we go to number 6 and look at the pH is out of the normal range, and that's partial. That's how you just follow it step by step. No matter what the number is, you can figure it out. This one I mentioned. And yeah, at the dendrite, we have if the sodium channel is opening up, that will lead to excitatory. If it's chloride or potassium channel opening up, that will be inhibitory. Okay, this one is just a background information, how the neuron like rush in of sodium that will lead to more positive, that's depolarization. And then later we will have the potassium voltage gated channel open up. So all the positive, these positive will move out, and that will lead to repolarization. And because the potassium voltage gated channel close very slow, that will lead to hyperpolarization. Then we have the sodium potassium pump slowly having the sodium I think sodium potassium pump. Let me check. Potassium pump. We have two potassium in, three sodium out. Yes, three sodium ions out of the cell and two potassium ion into the cell. And slowly we're going back to the resting potential, and until the next time a signal happens, for example, acetylcholine bind to the nicotinic receptor, and then the sodium channel open up again, more sodium will rush in, and this graph will go higher until -55. Boom, the threshold is reached, action potential is reached. So next signal is fired. And here for neurons, they have a period of time that they won't react to more signal. So after they reach the action potential, there's no action potential can be reached until they come downward to this relative refractory period. So at the absolute refractory period, even though there's more sodium rushing in, the neuron cannot react to it. It cannot contract again. Only until they reach the relative refractory period, if the signal is still strong, then more sodium can trigger another action potential. So it's like the muscle contracting really fast. That can be an example of tetany. This one I already mentioned in the lecture. And the brain parts is not important for the exam. This image is trying to show you how the neurotransmitter flows into different areas of the brain to have its function. This, it was mentioned in the lecture. Okay, so this spinothalamic tract, we are the nociceptor is triggered, and pain crosses over at the first order neuron, goes to the second one up. So here is crossover and goes upwards through the second order neurons to the thalamus. And thalamus will connect with the third. The second will be connect with the third at the thalamus and goes to somatocortex for you to feel pain and temperature. So only pain and temperature will cross over at the first and second neuron. Crossover is also called decussation. Here, how NSAIDs and Tylenol work. So NSAIDs has two functions. One, it will block this enzyme. This COX enzyme is able to convert to something, will activate the prostaglandin. Prostaglandin cause inflammation. Let me double check. Oh, no. So prostaglandin will send signal to the nociceptor. It prevents the conversion of this enzyme. That leads to less prostaglandin, which leads to less pain. And NSAIDs, the second function is to decrease inflammation. Let me double check if prostaglandin has the effect of decreasing inflammation. Prostaglandin. Yes, prostaglandin has the function of inflammation, pain, uterine contraction. Anyways, so by stop the conversion of this enzyme, we have less prostaglandin. And less prostaglandin leads to less inflammation and less pain. However, Tylenol it's only able to block some of the nociceptor. So Tylenol doesn't decrease inflammation, it only decreases pain. That's how these two meds work. It's important for the exam. Here we talk about opioids. Opioids, you know that not only is a pain blocker, it also causes addiction. So here we are going to talk about what happens. So I'll first talk about a normal passageway when GABAergic neuron release GABA and then prevents the dopaminergic neuron to release dopamine to send to the nucleus accumbens to the brain. In normal time, we do not need dopamine unless we do something and triggers the brain wants to give you a signal of reward or pleasure. They will stop the GABAergic neuron to secrete GABA. So no GABA means there is dopamine released by this dopaminergic neuron. And here, if we have opioid, we know that the end result of opioid gives you pleasure. So opioids binds at the end of the GABAergic neuron. This is the presynaptic neuron. This is the postsynaptic. So at the presynaptic neuron, we have an opioid receptor. Its effect is to close down this voltage-gated calcium channel. And we know that we need at the end of the neuron, we need calcium to rush in order to release neurotransmitter, which is GABA. So by blocking this, we have no GABA released. And then this neuron here, there's also another receptor, opioid receptor at the presynaptic neuron. So that has the effect of opening up the potassium and chloride channel. So more potassium is moving out, more chloride is moving in. Oh, sodium channel and blue. No, I don't think so. No, this one is a bit off. I have another drawing here. Sorry about that. So opioid will bind to the postsynaptic and the presynaptic, and if we have the calcium channel is closed down, we have no GABA released. Then this dopaminergic neuron will release dopamine to the brain. And let me double check about this at the PowerPoint. Diagram below shows two types of neuron. GABAergic. In the absence of opioid, neuron inhibit, therefore dopamine secrete into in the absence of opioid, GABAergic neurons inhibit dopaminergic neurons, and therefore dopamine secretion into the brain. In the presence of opioid, GABAergic neurons stop secreting GABA, thus enabling dopaminergic to secrete dopamine into the NSAID act by inhibiting dopaminergic inhibition by okay, so I think here they made okay, so if we have GABA at normal time, there's no secretion of dopamine at the end to the brain. If we have if opioid comes in at the end, this one. Yeah, I think my drawing makes more sense here. So if opioid binds to these receptors, there's no GABA. We don't have GABA, so nothing is inhibiting dopaminergic neuron to secrete dopamine. We get more dopamine to the brain. And if we say that the person is overdosed, we give naloxone. Naloxone will kick the opioid away from this receptor, and naloxone is binding to this receptor. So opioid is unable to bind to it, and now we go back to the original form. We have secretion of GABA at the end of GABAergic neuron, and no dopamine is released into the brain. This one I mentioned, only pain and temperature can cross over to the other side. at the spinal cord. So here I have a summary. By looking at the brain, this part is about light touch. So at the end, you'll determine which spinal injury the person has. If the person is able to feel light touch doesn't cross over. So depending on, let's say T3, the person starts to unable to feel light touch, that means the injury is at T3. If it's at left side, the injury is at left side. Right is right. There's no tricky part about it. Only the pain and temperature, that's here. Depending on so let's say it's again T3 left, the patient starts to unable to feel it. That means the right part of this brain, the corticospinal tract, is not working. And the gray matter is, which one? I wrote it here. So the pain and temperature. Oh, sorry. Pain and temperature is the gray area. It's not the circle. Is the gray area. So let's say if the patient T3 couldn't feel their left side. So this is left and this is right. So that means the right side of the brain is having injury. The spinal cord, sorry. Because pain and temperature cross over. And reflex is the circle part. And the light touch is the top part. Yep. Maybe they'll give you a description of how patient feel and then let you determine which region of the spinal cord has injury. But you don't need to memorize the name for each injury. All right, and you need to know about dermatome. Dermatome is that area of the skin that has connection with the spinal cord. And for muscles, for the last final lab you did, there's a page about the movement of muscle. So it's this page. Let's say we have elbow extension like that. Extension and flexion is the angle. Flexion is angle becoming smaller, and extension is this the angle of this joint is increasing. That's extension. So they will also tell you the origin of that part. For example, elbow extension here says origin is scapula and humerus, and insertion is the ulna. Ulna is this bone. So like that, you know that the muscle is contracting is the tricep. So these are important for the exam. For abduction, abduction is going away from the median, and adduction is into the median. How I remember this is DD, adduction has two same letters, so they're trying to become one. Two is becoming one. And abduction is the opposite. We have B and D, they are trying to open up. And Pronation is opening up, like a book opening up, and the other one. Subination is closing down, and dorsiflexion is coming up, and plantar, I think. 7. Yes, plantar. Plantar is like pressing on the gas pedal. Okay, I covered everything. Good luck with your exam.